Today we'll talk about the most important questions related to cardiac priority. Let's discuss the first question. A nurse is caring for a client who experienced an anterior wall myocardial infarction, or MI, 48 hours ago. During the assessment, the nurse detects a new systolic murmur heard best at the cardiac apex. Which action should the nurse take first? So here we need to focus on the key words. First is anterior wall myocardial infarction, and second is new systolic murmur. And then, what will the nurse do? Now we need to say, let's first understand this question. When a patient has an MI, then after the MI occurs, the myocardial muscles start getting damaged because they aren't receiving an adequate blood supply. Because of that, now here inside our heart, there are some muscles that we call papillary muscles. From here, some small thread-like structures emerge, and these thread-like structures are connected to the valve. So these valves, we call them the mitral valve. And when blood flows and the ventricles contract, these valves close like this. And after that, when the ventricle contracts, they don't go backwards because these threads are pulling them. And these threads are being pulled by these muscles, which we called papillary muscles. But when an MI occurs, then in an MI, all the myocardium in the area where the MI happens, that myocardium gets damaged. It's damaged, which means these muscles will also be damaged. And when these papillary muscles are damaged, they won't be able to pull these valves properly. If they don't pull, then what will happen? When the ventricle contracts, before it contracts, when they close, they will close like this. They'll be like this, but there's no one to pull and hold them back. So there will be a backward movement towards the rear. Because of this, when the ventricle contracts, as blood goes into the aorta, some blood goes back towards the rear. It leaks. Regurgitation occurs. So because of that, a sound is created. We call that sound a murmur. And this murmur occurs during systole. So that's why we called it a systolic murmur. So this means now that a systolic murmur is occurring. It's an abnormal sound. Now in this, what will happen is that blood is moving backwards. It's going backwards, which means there's less forward movement. And if there's less forward movement, then we can say cardiac output is low. Low cardiac output means low BP. The patient could go into cardiogenic shock. And the blood that's going backwards will go into the lungs through the pulmonary vein. This means there will be chances of pulmonary edema and pulmonary congestion. So this is the scenario we have. So now we've seen here that this problem is with the valve. It's a mechanical problem. So now let's solve this question. If a patient has a systolic murmur, what will the nurse do first? So in this, let's see, if this problem is a mechanical problem, then after that we see, for example, perform a 12-lead ECG examination. Now an ECG shows the electrical activity within the heart, not the mechanical activity. This means it won't show a problem occurring in the valve. So we'll exclude this. We'll eliminate it from here, while leaning that client forward. When the client leans forward, that's when you assess that sound as well. These are sounds like the aortic sounds, aortic and pulmononic sounds. We hear them from here. Like the aorta comes out from here and the pulmonary comes out from here. The pulmonary valve is here and the aorta comes out from right here. Actually, it comes out from here, but to make it simple, I've drawn this diagram like this. So there are some valves here called aortic valves. When these close, if there's regurgitation in the valve, then we can hear this sound, but we can't hear this one by having the patient lean forward. And anyway, in an MI, these valves don't get damaged. These valves here, because the papillary muscles here get damaged, that's why this valve is more affected, meaning our mitral valve is more affected, not this valve. So we'll exclude this option as well. Obtain an ABG. Now an ABG tells us the status of the pH in the blood, whether it's acidosis, alkalosis, partial pressure of oxygen, partial pressure of Colorado 2, it tells us these things. So it doesn't indicate valve-related problems either. So check for any change in the client's vital signs. Yes, first we need to assess what vital sign changes are occurring in the patient because we know this is a valve-related problem, and when blood moves backward, then the cardiac output will decrease. If it decreases, the patient will become hemodynamically unstable, so we must assess the patient first. So the correct answer here will be, hey, a client has just returned from a coronary angiography procedure. During the initial post-procedure assessment, the nurse observes continuous oozing of blood from the catheter insertion site. Which action should the nurse take immediately? So, whenever a coronary angiography is performed, we use the femoral artery for access. This means there's a puncture in the femoral artery, and since arterial pressure is high, oozing occurs, and the nurse has assessed this. Since the nurse has assessed it, what will the nurse do first? In this case, put on gloves and apply direct pressure to the insertion site. Yes, we need to stop the bleeding, so we'll apply pressure. This will be the correct answer. Monitor and record the amount of bleeding. Since there's active bleeding, there's no need to monitor it again, and we can't document it yet because documentation comes later. First, we intervene to stop the bleeding. So this is incorrect. Contact the healthcare provider. So if we contact the healthcare provider, because before contacting the healthcare provider, we must stop the bleeding by applying occlusion. So this won't be our priority either. Get protamine sulfate ready for IV administration. In some patients, when a cardiac procedure is done to prevent blood clots, the doctor starts a heparin infusion. So if the bleeding is due to heparin, we can anticipate giving protamine sulfate to the patient because protamine sulfate, it's the antidote for heparin, but the question doesn't mention that the patient is on a heparin infusion, so giving protamine sulfate makes no sense. A nurse is caring for a client who recently experienced a myocardial infarction, MI. While reviewing the cardiac monitor, the nurse observes the rhythm shown on the ECG strip. What is the nurse's priority action? So this is the ECG rhythm the nurse sees. Now in this rhythm, we can see the P wave, the QRS complex, and the T wave. This is a normal sinus rhythm, followed by this distance and then another P wave, QRS complex, and T wave. But look here, the distance has decreased, which means an early beat has started. So the first thing is an early beat, and second, the P wave is absent. See, this is the T wave, but right after it, the QRS complex starts directly. This means the P wave is absent here, and then this QRS complex is bizarre. This means the QRS here is wide and bizarre. If we see these three things together, we call it a premature ventricular contraction. Just look at the name. Contraction means a contraction is occurring. Ventricular means in the ventricle, and premature means it happens sooner than it should have. Why does this happen? Because the question states the patient has an MI, which is a myocardial infarction, and in an MI, tissues lack oxygen because of a possible blockage in the coronary artery, which stops the blood supply. So when the ventricular myocardium is damaged or destroyed, it becomes electrically unstable and starts firing on its own, leading to contractions. It no longer waits for an electrical signal to generate in the SA node, pass through the AV node, and reach the ventricle to contract. Instead, it starts generating impulses all by itself, and we call this a premature ventricular contraction. So as soon as the nurse sees this rhythm, they realize it has all three characteristics. This means there's only one PVC, and having just one isn't a major issue. It can happen. If there are more than 6 PVCs per minute, we must notify the doctor immediately. But if it's just one, we only need to monitor if any more PVCs develop after this one. We need to check if the patient is hemodynamically stable or unstable. These are the things we monitor. So one PVC is no problem. Now, let's look at the options in the question. Contact the healthcare provider, HCP? No. If you inform the doctor first, they'll just ask if the patient is stable or unstable and what their hemodynamic status is. What is the patient's heart rate? What is their blood pressure? If you haven't assessed that, it makes no sense to inform the doctor beforehand. Activate the rapid response team. Whenever you need to activate the rapid response team, you must remember a few things. The patient should be unconscious, hemodynamically unstable. They should have severe hypotension and severe respiratory distress. If these conditions are met, we can activate the rapid response team. Here, the blood pressure isn't given, so we don't know if the patient is hypotensive or not. SpO2 isn't given, so we don't know if the patient is in respiratory distress. We aren't told anywhere if the patient is conscious or unconscious. So this means the nurse first needs to see if the patient is conscious or unconscious. Whether they're hemodynamically stable or unstable, if their blood pressure is low or normal, for that, the patient must be assessed first rather than activating the rapid response team. So this is also a wrong option. Assess the client to determine their current status and evaluate their rhythm. Yes, we must assess the patient first. After that, administer the prescribed lidocaine. Lidocaine? Yes. What does lidocaine do? It corrects the rhythm, the cardiac dysrhythmia. But remember, assessment first. First assessment, then medication. So this will also be wrong.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations. Simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete review crash course. The link is in the description. Now, let's continue with the topic.
A nurse is caring for a client who recently experienced a myocardial infarction. The nurse notes 7 premature ventricular contractions. There are 7 PVCs here within a 60-second period, meaning 7 PVCs in 1 minute. Which action should the nurse take first? What will the nurse do first? So we need to see what a PVC is. It's a premature ventricular contraction. Inside the ventricle, the ventricular wall, the myocardium of the ventricle, has infarcted due to the MI. Because of that, it has now become electrically unstable and starts firing on its own, which causes contractions to start in the ventricle, which is called a PVC. If there's 1 PVC in a minute, no problem. If there are more than 6 PVCs, it means it's a serious problem. Or 1 PVC, or 1 normal beat followed by 1 PVC. 1 normal beat, 1 PVC, or we can say 1 sinus rhythm, 1 PVC, 1 sinus rhythm, 1 PVC. This is also abnormal. Or if 2 PVCs are together, that's also abnormal. Or if 3 PVCs are together, that's also abnormal. But if it's an isolated single PVC, then we don't need to do anything. But here, 7 PVCs are given. This means, now look, if an assessment option is given, then we'll do the assessment first. But if an assessment option isn't given, then let's see what other options are provided here. Administer the prescribed analgesic medication. Giving an analgesic won't resolve the PVC, wrong option. Notify the healthcare provider of the finding. So first, let's see if assessment is given anywhere here. Assessment isn't here either. And increase the IV rate. Assessment isn't given in this one either. So this means, what should we do now? Anyway, there are 7 PVCs, which means, because if there's 1 PVC, we'd assess it. Like, is this 1 PVC normal? Are there any more PVCs? There's no need to assess this. Now, inform the doctor about it, and anyway, an assessment option isn't provided here. So the correct answer here will be to notify. Increasing the oxygen flow rate to 5 liters per minute won't reduce PVCs. Increasing the IV infusion rate won't reduce the current PVCs either. The monitor technician notifies the nurse that the client has begun experiencing premature ventricular contractions after every beat, and what action should the nurse take first. So one thing you must remember here is that the technician, the monitor technician, noted and saw this PVC. The nurse didn't see it, the technician told the nurse. This means the nurse hasn't assessed the patient yet, and that technician reported that there's a PVC after every single beat. So what action will the nurse take first? Let's take a look at what's happening here. See this thing right here? This was on that monitor, a normal P wave, normal QRS complex, and normal T wave, which means a normal sinus rhythm. After that, what happens is there should have been a P wave here, but there isn't, and there's a direct QRS complex, which is also wide, bizarre, and an early beat. So if we find all 3 features anywhere, we call it a PVC. So this here is a PVC. So this is a PVC. After that, we see PQRST. This is a normal sinus rhythm. Then another PVC. Normal sinus rhythm, then a PVC. Normal sinus rhythm, then a PVC. This means after 1 beat, or 1 sinus rhythm, a PVC occurs. If this continues on an alternating basis, we call it bigeminy. What's the first thing the nurse will do? So bigeminy is not a normal condition. The doctor must be notified, but before that, it's essential for us to perform an assessment. Activate the rapid response team. Whenever you consider this option, you must check if the question states whether the patient is conscious or unconscious. If they're unconscious, we can activate the rapid response team. Is the patient severely hypotensive? If they're severely hypotensive, we can activate the rapid response team. But we aren't given the consciousness level, nor the blood pressure, nor are we told if they're in respiratory distress or not. Therefore, we will not activate the rapid response team. Assess the client's level of consciousness and obtain yes. We need to see that because whenever a patient has premature ventricular contractions, the ventricles won't fill properly. Since the contraction rate in the ventricle increased, it didn't have time to fill. Consequently, the ventricle won't fill completely, meaning cardiac output will drop. If cardiac output drops, the patient's blood pressure will drop, and it's possible the patient could have cardiogenic shock. So that's why we must assess the patient first, and assessing is the correct answer here. Notify the healthcare provider. If we notify the doctor before doing an assessment, the doctor will ask what the patient's condition is. Is the patient stable or unstable? Is the patient's blood pressure okay? Or what is the patient's level of consciousness? What would you do then? So it means we first have to assess the patient, and after that we notify the doctor. So this would be incorrect. Administer a prescribed lidocaine. Lidocaine is a medication we give later, after the assessment. So assessment first, then medication. So this won't be the priority here either. Which client has the highest risk of developing coronary artery disease, CAD? In which patient will coronary artery disease develop more? Now, whenever we talk about coronary artery disease, there are some risk factors, like being older or being male, where the risk factors are higher compared to females, because in females, before menopause, estrogen levels are produced. This estrogen prevents the development of coronary artery disease and protects cholesterol from building up inside the blood vessels. Besides that, obesity is also a risk factor, or any family history is a risk factor, and if the patient smokes, that's also a risk factor, increasing the risk. So looking at these things, see which patient has the highest risk. She's 34, which means the age is low and she's a woman, meaning the risk is lower in women than in men because estrogen acts as a protective shield, and she has a history of mitral valve prolapse but stopped smoking. Since she stopped smoking, her risk will be lower. A 45-year-old man, 45 is also okay, not too old, but the risk is higher in men than in women, and he has a strong family history of coronary artery disease. He has a family history which increases the risk, but his total cholesterol level is 165 milligrams per deciliter. The normal cholesterol level should be below 200, meaning it's in the normal range, which is good, so the risk is also low here. A 58-year-old, so the age is higher now, an old man, a statin. Statins include those spread that lower cholesterol, like atorvastatin, simvastatin, and rosuvastatin, and he's on medication and has an HDL level of 62. HDL is considered good cholesterol because it protects the patient from CAD. Now in this case, the normal HDL level we should have is more than 60 milligrams per deciliter. Since this is 62, it's normal, which is also good, so the risk is low for this patient too. A 67-year-old. So 67 means this patient has the highest age among them, so she's the oldest, and she's a woman. Being a woman means that after 67, she has gone through menopause. And after menopause, this woman no longer has estrogen. This means the protection she previously had from estrogen is gone. Besides that, obesity is also a risk factor. LDL is bad cholesterol, so it increases the chances of coronary artery disease. 190. The normal level for LDL should be less than 100 milligrams per deciliter, but this is elevated. Look here. The LDL level is high. The patient has obesity. She's a 67-year-old woman. This means she's a postmenopausal woman, so this one will have the highest risk factor. A nurse is providing discharge teaching to a client diagnosed with unstable angina. Which findings should the nurse instruct the client to report to the healthcare provider immediately? Angina means the oxygen supply to the heart has decreased while the demand has increased. And there are three types: stable, unstable, and Prinzmetal. Stable angina is when the patterns of angina or pain are predictable. This means if there's a trigger, there will be pain. For example, if activity increases, there's pain. If they rest, the pain will decrease. If the patient is given nitroglycerin, the pain will decrease again. So it means the patterns are predictable. But in unstable angina, the pattern is not predictable, meaning the patient can have pain even while resting, and even if nitroglycerin is given, the pain doesn't subside. There's another type we call Prinzmetal angina. Prinzmetal angina means that there's a vasospasm within our coronary artery, which causes the blood supply to the heart's myocardium to stop, and because of that, the patient develops angina. So now we're talking about unstable angina, and unstable angina can at any time turn into a myocardial infarction. So now we need to identify things that act as precursors to unstable angina and could turn into a myocardial infarction at any time, Look at this, chest discomfort after moderate physical exertion. This means chest pain that occurred after some exercise. This means it's predictable. So we can eliminate this. We're talking about unstable angina, which should be unpredictable. Chest pain occurring during emotional stress. This means it's also happening due to a trigger. So this is also predictable. Chest discomfort during sexual activity. This is also happening because of increased activity. This means it's also stable. Then, chest pain that changes in frequency, duration, and intensity. This is an example of unstable angina and can turn into an MI at any time. So the correct answer here will be this. A client has just returned after undergoing a balloon valvuloplasty for mitral stenosis. Which assessment findings should the nurse address immediately? There was stenosis of the mitral valve, so it had narrowed. To widen it, we used balloon valvuloplasty. Which thing would require the nurse to perform an immediate intervention? A soft grade 1 mitral regurgitation murmur is heard. We can divide it into 4 categories: grade 1, grade 2, grade 3, and grade 4. Grade 1 is mild, where the patient's blood flows backwards slightly, meaning there is regurgitation, but it's not very serious and doesn't cause symptoms. In grade 2, the regurgitation is more significant and the patient starts showing some symptoms. In grade 3, the regurgitation increases, leading to more symptoms. And in grade 4, which we call severe regurgitation, the blood moves from the ventricle back into the atrium. It's quite severe. And then the cardiac output will decrease, potentially leading the patient into hypotension or shock. Additionally, the regurgitated blood enters the atrium and can then move into pulmonary circulation, causing pulmonary congestion and edema. This means grade 4 is the most serious, grade 3 is slightly less so, grade 2 even less, and grade 1, well, that one isn't considered serious. When we perform a balloon valvuloplasty on a patient, grade 1 mitral regurgitation is actually an expected finding, so the nurse doesn't need to take any immediate action for it. Oxygen saturation of 94% on 2 liters per minute via nasal cannula. The nurse doesn't need to do anything about this either. The client is becoming increasingly drowsy, meaning the patient is somnolent or lethargic. Whenever a patient becomes drowsy, you must consider that they might be having a stroke, or perhaps their cerebral perfusion has decreased. It's also possible an embolism has formed, and that's why the patient is experiencing this drowsiness. Since this is a neurological symptom and indicates a neurological problem, we need to intervene immediately, making this the correct answer. Urine output has decreased from 65 milliliters per hour to 45 milliliters per hour over the past hour. Normal urine output is 30 milliliters per hour, so since it was 65 and is now 45, it's still within the normal range and the nurse doesn't need to act. What action by the nurse is most effective in reducing the risk of wound infection while changing a dressing for a client recovering from coronary artery bypass graft or CABG surgery? Well, performing hand hygiene before changing the dressing. Perform hand hygiene before changing the dressing. Yes, most microbes are found on our hands, so before starting any procedure, you must perform hand hygiene. Hand hygiene is the best method for preventing cross-infection, so this will be our priority here. Next, cleaning the incision site with an antiseptic solution. While using an antiseptic can prevent infection, if you haven't washed your hands, the dressing itself will become soiled. So washing your hands first is essential. These other steps come later. Applying a prepackaged sterile dressing over the incision site is also necessary to prevent infection, but hand washing must come first. If you don't wash your hands, the sterile dressing itself will get contaminated, so this is also incorrect. Finally, disposing of the soiled dressing in a biohazard container happens only after the dressing change is complete. The nurse is caring for a client who has suddenly become unresponsive. The client's blood pressure is 82/42. This means the patient is hypotensive, the patient is unresponsive, and the SpO2 is 89%. This means the patient's saturation is also low while receiving 50% oxygen via the face mask. What is the nurse's priority action? Start chest compressions. Look, whenever we need to start chest compressions, 2 things are necessary for that. 1, the patient must be unconscious, and along with that, pulse must be absent. But here, see that the patient is unresponsive, but their pulse, Look, because the pulse isn't mentioned anywhere, but because if the BP is given, it means there's blood pressure. This means there's cardiac output. Cardiac output only happens when there's a heart rate. So this means the patient's pulse is present, which means we don't need to perform chest CPR initially. Activate the rapid response team. Whenever you see in a patient that the patient is unresponsive, the patient is severely hypotensive, or the patient has severe respiratory distress, then in that condition, you can activate the rapid response team. So look here, the patient is unresponsive, hypotensive, and has respiratory distress as well. So what will you do for the patient now? You'll activate the rapid response team. Ask the family members to leave the room. This isn't necessary right now, meaning this isn't our priority here at the moment. Provide ventilation using a bag valve mask device. Ventilation, bag mask, this isn't our priority either. A higher priority would be to activate the rapid response team. So these were our 10 most important questions. See you tomorrow in a new lecture. Thank you.